Hi, I'm Rena Conti. I'm a health economist at the business school, and my focus is on the convergent themes of innovation in life sciences and racial disparities. So rare disease affects approximately cumulatively 1 in 10 Americans, and treatment consumes approximately 1/4 of the $4.2 trillion we spend on healthcare annually. Many vulnerable patient populations are vulnerable to rare disease, and this includes people who are a member of racial and ethnic minorities and also children. Due to both lack of treatment modalities to take care of their disease, but also our very complicated healthcare system, persons with rare disease face disparities, both in access to therapies, including clinical trials, but also access to standard of care. And in addition, there are disparities in outcomes. Due to fundamental investments of our tax dollars in research and development, we now have many new advanced therapeutics that are addressing rare disease. These therapies are quite expensive, on the order of $500,000 per treated patient or even more. And there's been a lot of worry that the advent of these therapies are actually going to really significantly push out our annual spending. There's very little data on this topic, and consequently, my colleagues and I at MIT built a simulation model where we estimated the expected spending on these advanced therapeutics overall per year over the next decade, and then we also disaggregated by payer. Here's what we found. We found that at peak expected spending, that these therapeutics would add approximately $65 billion with a B dollars to our $42 trillion healthcare budget. That's 1% or less of total spending, and it's fundamentally a drop in the bucket. But here's what's interesting. What we found is, unlike many other medical technologies that have come and transformed our lives, these technologies actually target state Medicaid-insured patient populations and commercially insured patient populations. And that is a little bit of a challenge. Why? Well, these payers face annualized budgets, and the only way that they can fund new spending is by either going to taxpayers and asking Congress to raise their spending limits, or by raising premiums on employers and employees. And in fact, in a new paper on sickle cell, we estimated that the annual premium per member per month to fund these new therapeutics would raise premiums by approximately $5 to $10 per person per month. So it's a big hit. So I've been working on this topic for 15 years, and I had a working hypothesis. The working hypothesis is that with the advent of these new therapies, spending might get pushed out, and actually disparities might compress. However, structural barriers to access to care might actually mitigate spending on these therapies and might actually increase disparities. Moreover, there's a potential spillover effect on innovation. The less we pay or are willing to pay for these therapies, the more innovators might not actually innovate in this space. We believe that this research agenda and the products of our research agenda have policy impact, but also are quite of interest to innovators at the university and also more generally in the private sector. With that, thank you.